spinal system and director of the Spinal Oncology and Invasive Spine Surgery program. And he's going to be speaking on acute spinal cord injury, multimodal intervention.
Thanks, Ed. So, slide ready to go? Good, okay. So first let me just tell you, do I have a... So first, let me thank you all for being here today. Obviously, this is a great group and a great opportunity for us to discuss a lot of the things that we're currently doing so that we can make sure that we're all on the same page, as well as talk about where we really need to be. And I certainly appreciate Dr. Ullman and Dr. Margettis for laying the groundwork for some of what I need to discuss, which is that of the multimodal treatments that we're doing, we're really doing it all wrong. And so we really need to start from scratch in many ways to advance the techniques and technology, because what we're doing isn't enough. So first, as a disclaimer, I am an involved surgeon. I work with a number of these companies to try to improve their techniques, but I make less than $10,000 a year for these people. It's more of a minor hobby than a business for me. So I'm on both the medical advisory boards for spinal cord injury research companies, as well as being the CEO of a startup that I made to try to put myself and these companies out of business. We're actually developing a technology that will try to prevent spinal cord injury in people who are at risk wearing these devices in the future. Not there yet, but we're getting there. In addition, one other disclaimer, I will be discussing some non-FDA approved techniques and technologies, so be aware, and I'll try to flag that where it's relevant. So what to expect? I'm going to tell you the scope of the problem. I'm going to tell you the complexity of the problem, and specifically the complexity of a spinal cord injury. Dr. Margettis has already given me, painted a lot of that for us, so I don't need to give enormous detail, but it helps to understand. We'll talk about the current state of the treatments in America, what's available, where to go to get it, what we have, and where we need to be, because we're definitely not there yet. So first of all, the scope of the problem of spinal cord injury is it has an enormous and depressing impact upon our society and upon the people, not just the individuals, but their entire families. Spinal cord injury is a common enough problem. It happens 30 times a day throughout the year, but the majority, more than half of all spinal cord injuries occur between Memorial and Labor Day. So we have entered into now the season of trauma, where we will have 60, not 30, but 60 spinal cord injuries every day until Labor Day. So this is a huge impact. It's a nationwide problem. It causes our multifactorial injuries, violence. Diving into swimming pools still happens. No matter what you tell them, what your grandmother tells them, they're still going to dive in a shallow end of a pool or at a lake or someplace where they don't know where they are. So the chances of improving are abysmal. You have an ASIA A, the ASIA, the American Spinal Cord Injury Association. If you have an ASIA A, which is of course the only grading system where an A is a failing grade, but the ASIA A means you cannot move and you cannot feel below that level. It is absolutely no function. An ASIA B is not much better. You have some sensation below the level of injury, but no motor function. And an ASIA C is still not much better than that. You have some movement, but it's not functional. You can't walk. An ASIA D means you're weak, but you have retained enough function to be somewhat independent. And an ASIA E is basically intact. With the current standard of care, your chances of improving are about 3 to 5% if you're an ASIA A. And you do have a good chance of getting better if you're a B, because some signals are getting through, but you also have a chance of getting worse, of losing even that little function. The costs are staggering. Trillions, not billions, trillions of dollars go into caring for spinal cord injury patients. Billions and billions a year. Look at this, $1 million per patient for a high spinal cord injury. And even for low spinal cord injury, that's it's still $250,000 a year just to care for that patient in their first year of care. Every single year this happens. 12,000 times a year. And the cost of treating one over their lifetime is staggering as well. It bankrupts entire families trying to deal with the enormity of this. And right after they get bankrupted, they go on Medicare, Medicaid, and we're paying for it. So if there were some way we could stop this hemorrhage of money, and not just money, but talent, because it affects the youngest people in our population. It affects people for their entire life, because we've gotten good enough, we can keep these people alive an awful lot longer. So there's a lifetime of cost and care, and a lifetime of lost opportunity, not just for the person injured, but frequently there's a family member who has to give up their work to continue to care for this person because their needs are so great. So imagine if we could take some of this money off the table by changing the outcome. If we could just take 1,000 of the 12,000 patients a year and transition them from an Asia A through C into an Asia D, somebody who can care for themselves, that would be $3 billion over the lifetime of these 1,000 patients. It would be $3.5 billion in indirect savings of allowing that other person to go to work, allowing this person to go to work and earn money, earn benefits instead of being paid benefits. It's a staggering impact on society. It's a drag on everything we do every day. Why aren't we there yet? The spinal cord injury is complicated. There's a lot to it. It's not just one gene that's gone awry and a tumor growing in one place. It's a series of trauma to multiple parts of the nervous system. You've got bone compressing and damaging the cord. You've got broken bone that's supporting the spine itself. You've got shearing injury, where in many cases the spinal cord is actually being dragged. It's being put under tension. In this particular case here, you can see that the patient has actually a slide forward, which is actually distracting his spinal cord. In addition, you can see the scissoring of this particular fracture. And I'm going to get back to this guy at the end, just to tell you a little bit of a story about that. In addition, and Dr. Margettis touched on this as well, there's a whole host of secondary injury cascades, each of which damages a different part of the nervous system. You've got swelling in a fixed cavity. The spinal canal is a fixed cavity until we operate. And within that fixed cavity, much like head injury, swelling in a fixed cavity leads to death of cells. Hypoperfusion leads to ischemia of the tissue. And we don't have, in the spinal cord monitoring, ability to have an intracranial pressure like they do in brain injury. We can't put a pressure monitor and figure out what the spinal perfusion pressure is. We just have to make assumptions. We're basically back where they were 40 years ago. Then there's excitotoxicity. As the cells are damaged, they release glutamine, spill it into the surrounding area. That excites the cells, and they fire, not having any circulation to replenish, and they die. So this all leads to loss of cells, loss of neurons, and loss of the environment in which they can recover. And here's a little bit of a diagram of some of the molecular cascades that contribute to this cell death. And you can see there are entire different receptor processes, each of which causes cell death or cell dysfunction. So it's not just one part of one simple injury that we can just fix that with one drug. But it actually is going to take a village to make this spinal cord injury patient better. Then there's late effects. You've got glial scar formation, which where the damage was, that creates a physical barrier to neuronal regrowth. And then there's tethering, scarring and adhesions that develop within the spinal canal that also put the spinal cord under tension. In this particular case, if you look at this one here, the one in the center, the cord is actually being stretched because it's tethered posteriorly, tethered anteriorly, and as scar heals, it shortens. So over time, it's actually pulling the spinal cord in two opposite directions. I think. And then there are humoral, there are protein and local receptors that block the progression of neurons back to where they need to be. There is the capacity for neural regeneration in the nervous system, but there are humoral factors that prevent it from happening. So what do we need to do? Well, we know that in addition, we've got to control the physical environment to maximize the patient's best recovery. We know that low blood pressure is caused partly by the loss of the systemic vascular resistance from the cord injury itself. That causes all the blood to pool in the periphery instead of being driven back to the center where it needs to be, and that causes the pressure to drop. In addition, you can have anemia, partly because the patient may have had other injuries that they're bleeding to death. You can have hypoxia, they may have an airway problem. And then altered mental status may lead them to go do dumb things, like move around against their better judgment. And then there could be electrolyte anomalies. And then all of these can lead to lower blood pressure. So it's a vicious cascade that we need to support. Current state of treatment in America, there are more than 5,000 certified emergency rooms in the U.S., but less than 500 level 1 or level 2 trauma centers where the most advanced forms of general surgical, general trauma are practiced. And less than 50 centers in America where there is an active clinical trial of a novel or new treatment for spinal cord injury. And some of these aren't even all that novel or new. They're there, they're at least being done. And that's according to the US clinicaltrials.gov website. This is a general overview of where you can get to a level 1 or level 2 trauma center in America. Look how much of the America isn't even covered by that. Fortunately, on the East Coast, you have a better chance of at least getting to a level 1 or level 2 trauma center with 60 minutes of travel time or less. It's not really great. But it gets even worse when you look at this. These are the locations of any acute spinal cord injury clinical trial. Not many. It's hard to get to them. And then when you look at the Northeast, where we live, there's actually nothing north of New York. Nowhere in New England, and only in New York City for all of New York State. That's 35 million people who are being served basically by only one site, Sinai, that has any acute clinical trials that are going on. Why is that a problem? Well, we know that there are some basic things we can do to try to improve the patient's environment as soon as they get to us. ABCs, okay? Airway, breathing, circulation. Imaging, we've got to find out what the problem is. Then we're going to start doing things right off the bat, and we're going to start planning for the next and the next and the next stages. We're going to give them drugs, or we're going to give them surgery, or we're going to put in monitors, or we're going to do devices that we stick into the body, such as traction, or potentially as a research option, cooling, things like that. So next, we're going to look at the immediate treatments. Well, what we got stabilization, put them in a collar, put them in traction. It's controversial without MRI because of the possibility of having a disc herniation and the concern that you can actually make that worse if you put them in traction without knowing what the problem is. Pharmacological, well, one area we know that works is raising the blood pressure. We didn't figure that out until 1997. And it's not even always done. There's even controversy about that. There's some people who question the value of raising the blood pressure in an ischemic and hypotensive patient. Steroids. Quick show of hands. How many people would give steroids to a patient in their emergency room? How many patients would give solumetric protocol or steroids to a patient? How many people would not give steroids? Okay. I can tell you that it is a very nuanced discussion. I can also tell you that the treatment protocol for the New York Jets has us giving everybody who's injured on the field, not in the stands, in the field, steroids because we believe that the risk to an otherwise uber healthy patient is very low. But for any potential impairment in their physiology, that to me is actually a no-go. And I would not give it. In fact, colleagues, I always tell him, I don't want to be given steroids if I come in with spinal cord injury. And he says, I'm going to give it to you whether you want it or not. So the evidence is very weak. In fact, the most recent guidelines actually said the evidence of detrimental effects is stronger than the evidence of beneficial effects for steroids. And we know that we don't give steroids in head injury. So why are we still giving steroids for spinal cord injury? Invasive treatments, induced spinal hypothermia, that's still very controversial. But it sort of makes sense. We do some things like this in head injury and other forms of neurotrauma, neuroinjuries, and neuroemergencies. But we're still even debating the timing. Another quick show of hands. How many people in the audience would want their surgery done within 4 hours of their injury? How many people would want it done at least within 8 hours of injury? I mean, at least, meaning sooner would be better. How many people would want it done within 24 hours of their injury? How many people would want to wait 14 days to have their injury treated surgically? But there's a site in America that's actually still being randomized because they still think that there's validity to the concept. We should wait and see what happens. When every single animal model shows benefit to the immediate or earliest possible decompression. So we know that we want to get the blood pressure up. Mean arterial pressure greater than 85 seems to be the target that works the best. We want to prevent complications because the longer you put off treatment, the more likely you are to get complications of immobility. And that has been shown. It hasn't been shown adequately. The evidence is not strong enough, partly because of the numbers involved, for a benefit to early intervention surgery. But there is a clear benefit to the early intervention to prevent non-neurologic complications. And of course, the earlier you intervene, the earlier you can often get them off the ventilator. So, steroids, it's an option. Rizulol is another experimental pharmacologic agent. Nobody really knows. We know that we should do some form of decompression, though, when there's some form of obvious anatomic problem. If there's compression, do a decompression. If there is deformity, do a deformity correction. If there is distraction, you want to do the deformity correction. And then if there's a contusion, if there were a brain injury, you'd probably want to evacuate the contusion if it's sizable enough. Spinal cord injury, that was done back in the 50s, but then it was abandoned. And I think that's something that might actually need to be brought back up. We also know there are a number of experimental protocols going on right now. Surgical treatments, including the in vivo scaffold, which does involve evacuation of a contusion in the thoracic spinal cord and placement of a small matrix that has been shown in animal models to promote regrowth through the area of injury. Vertex is another one that's formerly known as Cephalin, which promotes regrowth by blocking some of those inhibitory factors, the factors that stop neurons from regrowing. Expansive duroplasty has been advocated that you do a laminectomy and then expand the dura by putting a patch into it so that the cord is not being strangled by itself. Detethering procedures, they're often done in a delayed fashion. Is there some value in doing it early? Spinal cord cooling. It's been suggested that if you opened up the spinal cord, or up to the canal and got down to the cord and cooled the spinal cord directly, that could have benefit. So there are cellular replacement treatments. There are stem cells and other similar cells that are being injected. They're currently being done in chronic injuries, but should we be intervening early to try to replace the damaged or destroyed cells earlier, before the necrosis, before the die-off of the distal neurons? Should we be replacing those cells at an earlier time point? And then there's even been proposed in the animal literature using radiation. You actually radiate the area injured, and the animal models have shown an improvement in neurologic function. Maybe that blocks the glial scar from forming in the first place. Maybe there's a bystander effect where you knock out a few cells with parallel beams of radiation, and then the others grow back in because you've cleared the path. We don't know. But what we do know is we need to get to a better place. We need to learn from the successes in other areas. For example, pediatric brain tumors, they pretty much do not treat any children with brain tumors without being part of a research protocol. In addition, head injury, there's a lot of good trials going on. We need to get everybody together and doing more patients enrolled. The current system for treating spinal cord injury I'm going to propose is the same as your car has just been totaled in an accident. We're going to replace one part at a time. You're going to go to one center and they're going to replace the door and see how you do it. You're going to go to another center and they're going to replace the driver's side tire and see how you do it. Or maybe the fender at the third side and see how you do it. And we'll see, maybe if after this we'll say, hey, maybe replacing the fenders is a good thing. Instead, what we need to be doing is have, instead of local emergency rooms and regional spinal cord, we need to have regional spinal cord centers. You need to have at least one level 1 in each area that's designated as the poly trial, and then several that are all part of a larger network of research trials that are all moving the bar forward. We need to get people who are motivated and interested and are willing to operate on these people quickly and get these patients to those centers. We also need to have a presumption of participation, because the outcomes without participation is already so bad. You can be doing worse. What we really need is to have a matrix where we're enrolling thousands of patients, not scores of patients, but thousands of patients, where each one is getting one of these different mechanisms treated. You have a trial where you get one of these 4, control, lumbar drain, expansive neuroplasty, myelonic. And then they would also be getting either steroids or Rizulil or Cephalin or something else, or nothing. Ischemia, induced hypertension with nimodipine. We know there's subarachnoid hemorrhage in these patients. We use nimodipine with subarachnoid traumatic and spontaneous subarachnoid hemorrhages. We're not doing it. What can we be doing? We need to be doing more. Right now, we're not doing much. We need it because if we could enter thousands of patients in these spinal cord injury trials instead of single digits, we could have real data in a few years and make life-changing changes, hundreds of thousands of people per year, and save trillions of dollars a year. Some of that money comes out of our taxes, some of that money comes out of the insurance, some of that money comes out of people's life savings. Trillions of dollars of savings a year. I thank you for your attention.